In Chapter 22, we will look at respiratory infections. In this recording, I'm only going to look at the structure of the respiratory system and bacterial respiratory infections because there are so many of them. I'll post another video, part 2, with the viral and fungal infections of the respiratory system. So as we look at the respiratory system, we see how the ear, the middle ear, is connected to the throat via the eustachian tube, and this opens into the nasopharynx. So there's an opening in the nose, essentially behind the nose, for the eustachian tube or the auditory tube. You can see that there's a little label here where it comes in. As we look at the respiratory tract, we see a lot of different structures going on. We have the sinuses, we have the nasal cavity, the mouth, then we have the throat, and there are 3 parts of the throat essentially: the nasopharynx, the oropharynx, and the laryngopharynx. So the nasopharynx is the upper part of the throat. It's what actually connects the nose and the throat together. You may not have really realized that the nose and the throat the nose and the mouth were connected until you were taking a drink of Coke and you laughed and Coke came out of your nose. And so the nose and the mouth are connected. And then we have the oropharynx, which is what we commonly think of as the throat, okay, at the back of the mouth. And then we have the laryngopharynx, which is the lowest part of the throat, and this is very close to where the larynx, or the voice box, where our vocal cords are found. And then going deeper, we have the trachea, which leads us to the lower respiratory tract. So this portion, the nose and the mouth and the throat, are considered to be the upper respiratory tract. And then once we get past the larynx, get into the trachea or the windpipe, and then down into the lungs, we consider that the lower respiratory tract. When we look at the tissue that lines the respiratory tract, we will see this mucous membrane. We'll see a particular type of cell called the pseudostratified columnar cells. These cells are intermingled with the smaller cells called goblet cells, and you can see one highlighted there for you. And the job of goblet cells is to produce mucus. So the goblet cells produce mucus. This mucus, of course, is sticky, helps to trap dust and other particles and pathogens, and really tries to prevent them from getting down any lower down into the lungs. You'll also see cilia. The cilia are little hairs on the surface of the cells, and their job is to act like little brooms, to take this collection of gunk, essentially, that this mucus is collecting, and sweep it back out of the respiratory tract. And these two together, the mucus and the cilia, are sometimes referred to as the mucociliary escalator. And the job of that is really to try to prevent pathogens, dust, mold spores, pollen, anything in the air from getting down into our lungs. When we look at airborne bacterial diseases, okay, and when I say airborne here, I'm meaning anything transmitted by the air. So I'm talking about both droplet transmission, which is a form of contact transmission, as well as true airborne disease, which is when the droplet, or when the particles are smaller and they stay in the air longer. Humidity and temperature of the air determine how long the bacteria can hang out in the air, essentially. Air, you see there is a passive transmitter. We have upper respiratory infections, URIs, and then we have lower respiratory infections, LRIs. And we'll look at both of these. So the first upper respiratory infection that we're going to look at here is what we commonly call strep throat. And strep throat is caused by our good friend Streptococcus pyogenes that we looked at in chapter 21. Like I mentioned before, Streptococcus pyogenes is a bad dude. At least six different enzymes, 4 different toxins. Basically what happens is the pathogen gets in there, starts causing inflammation in the skin of the throat. So we get a sore throat, we get fever because it's going to produce what are called pyrogens, which help generate fever. Malaise, that overall feeling of, you know what, I just really don't feel good. Pus in the throat, swollen lymph nodes, swollen tonsils, if the individual still has tonsils. If the particular strain of strep that's causing the strep throat produces a particular type of toxin called erythrogenic toxin, then it can lead to what we call scarlet fever, which is when a rash starts to spread over the surface of the body. Rheumatic fever, which is a condition of the heart valves, and glomerulonephritis, which is kidney disease, can occur if the strep goes untreated. Not really any way to prevent it. Don't drink after people. Don't, stay in close proximity to people who may have strep throat or who have strep throat. The good thing is it's easily treated, responds well to antibiotics. So Streptococcus, again, the cocci being round, strepto meaning chains. So Streptococcus are chains of round-shaped bacteria. They are gram-positive. This is a scanning electron micrograph here. Here is the gram stain. Again, you can see it's purple because it is gram-positive. Here's an example of strep throat. You see how red the throat is. You see the pus that has accumulated on the back of the throat. Another instance of strep throat where you can, again, kind of see the redness all back in here. See how swollen the tonsils are as well. Scarlet fever can lead to what we call a strawberry tongue, where the tongue turns bright red and the papillae, which are the little bumps on the tongue, become swollen. So the tongue takes on the appearance of a strawberry. The rash of scarlet fever is very pronounced. It doesn't have that lacy or dotted appearance like we see with other rashes. It's very diffuse. You'll notice in this image, you don't see a lot of skin that isn't covered by rash. So this is characteristic of scarlet fever. Of course, we know the word scarlet means red, and this is indicative, excuse me, of the body, in essence, turning completely red. So rheumatic fever from prolonged or untreated strep infections. So here is a heart valve, and what you'll notice along the edge are these little areas that are kind of darker, these little circular areas that are kind of darker. Basically what has happened is that the bacterium has eroded this tissue here. It can lead to heart valve damage. Now, we talked about otitis externa in chapter 21. Now we're going to get into otitis media, and we consider otitis media as a respiratory infection because the infection comes from the throat up that eustachian or auditory tube. There are a lot of different pathogens that can cause otitis media. You see there Streptococcus pneumonia is most common, but E. coli, Enterococcus, the group B streps can all be involved. Viruses can also cause acute otitis media. And one of the video assignments that you have is kind of this wait and see approach to determine if an antibiotic is necessary. So basically what happens with otitis media is the pathogen will make its way up the auditory tube from the throat to the middle ear and will start to cause inflammation in there. It will start to, so the body will start to produce fluid, so you'll get this fluid buildup behind the eardrum. So there's pain that's associated with that. Fever can result, vomiting and diarrhea, especially in infants. Ear infections are often linked to diarrhea. Amoxicillin has always really been the drug of choice, but some of these pathogens are starting to exhibit antibiotic resistance, so you may have to go to a macrolide or a cephalosporin or even a fluoroquinolone to get rid of the infection entirely. You see there, it's the second leading cause of visits to pediatricians by children younger than 5 years, and it's the leading indication for antibiotic prescription. But we are changing our thinking on this a little bit. So here you can see in photo A healthy tympanic membrane. You can see the bones there. In B, you see actually a torn membrane, like the eardrum has actually ruptured. You can see that the bones of the ear have actually kind of started to erode, and you see this mucus build up in here that has resulted, or that has occurred as a result. The other issue that we worry about with otitis media, especially in young infants, is that it can affect their hearing, which can then affect their speech, because they learn sounds by hearing other people make those sounds. So if they have chronic ear infections, they don't hear those sounds as well, which can lead to delayed speech or speech impediments. Unfortunately, one that we don't have to worry about anymore is diphtheria. Diphtheria used to be a problem a long time ago, but fortunately we have a vaccination program for diphtheria. What happens is if a person is infected with a particular strain of the bacterium that produces the diphtheria toxin, it destroys the cells in the throat, and so it causes a sore throat and pain. Well, as the tissues become damaged, then pus starts to build up there. The fluid starts to ooze, and this forms what we call a pseudo membrane. The pseudo membrane can grow so large that it actually interferes with breathing. It basically cuts off the opening to the trachea, so no air can get through. Since it is the toxin that's causing the damage, it's best treated with an antitoxin and then with an antibiotic to kill any remaining bacteria so that they don't produce any more toxin. The vaccine that's given is a toxin vaccine. So what we're receiving is really a small portion of the toxin, since that is what causes the damage. You see there, in 1921, there were 206,000 cases of diphtheria in the United States, and 15,520 children died as a result. But once we started vaccinating, the rates dropped quickly, and you see there in 2003, or since 2003, only 2 cases have been reported in the United States, 2012 and 2014. So here is a stain. This is an endospore stain where you can see those little spores at the end of each of the bacteria. This is a picture of that pseudo membrane. So you notice how red the throat is here, and you see this pseudo membrane that's forming. Now this one is relatively small, but what's going to happen is this is going to continue to grow unless the child receives treatment. Think, okay, why don't you just go in there and remove it? Well, This pseudomembrane is where all of the bacteria are trapped, and also this toxin is destroying these cells, so it's opening up blood vessels. So the problem with going in and surgically removing the pseudomembrane is that now you have bleeding that can result, and you have the threat of the toxin getting into the bloodstream and becoming a widespread systemic infection. Now, pneumonia is a term that we throw around a lot, and it is a lung infection. That is what pneumonia is. There are a lot of different causes of pneumonia. Pneumonia can lead to another condition called pleurisy. So to understand kind of how this works, you have to understand how the lungs are situated in the thoracic cavity. So the lungs are encased in what are called pleural membranes inside the pleural cavity. So there's this opening, this cavity, and inside that cavity we have the lungs, which are lined by a pleural membrane. Now this pleural membrane lines the cavity wall as well as the outside of the lungs. And this membrane, this pleural membrane, is what we call a serous membrane, in that it secretes serous fluid, which is a watery, lubricating fluid. Now, every time we take a breath, the lungs rub over the surface of this cavity wall. But because the serous fluid is there, it does so with no friction. It just slides right past. But in pleurisy, these pleural membranes become inflamed or infected. This leads to a decrease in the production of serous fluid. And if there's little to no serous fluid, now the lungs, when they slide past the cavity wall, feels more like sandpaper. So it's very painful. So every time the person takes a breath, the lungs basically scratch over the surface of the cavity wall. So pleurisy is a very painful condition. When we look at bacterial pneumonia, we have three major bacterial species that are going to cause the majority of cases: Streptococcus pneumonia, Hemophilus Influenza, and Mycoplasma pneumonia. There are other bacterial causes, but these are the three major causes. So we're going to look at streptococcal, or what we commonly call pneumococcal pneumonia. So Streptococcus pneumonia is very closely related to Streptococcus pyogenes, but it's so named because of its prevalence in causing pneumonia. A lot of people carry this around in their throat, but it can get into the ears and cause otitis media. It can get down in the lungs and cause pneumonia. It can get up in the sinuses and cause sinus infections. And so it produces a capsule, which allows it to hide from the immune system. It secretes some different types of enzymes that damage cells and allow it to get down into the lungs and kind of stick. High fever, shaking chills, a productive cough, bloody sputum, and chest pain. So streptococcal pneumonia is kind of like, bam, here I am, you have pneumonia. High fever, productive cough, which means you're going to be coughing up stuff, and it may be bloody because of the damage that's being done to the cells in the lungs. Fortunately, there is a vaccine for children and the elderly, the PCV13 or PPSV23. So children can get this vaccine, and then those, I believe it's over 55 or 60. And then it's also made available to people with other like lung disorders like asthma, because they are more susceptible to developing pneumonia. Treated with penicillin, macrolides, or fluoroquinolones. Fortunately, it's easily treated, but even for healthy individuals, they may wind up in the hospital because they're going to have trouble breathing in a lot of cases. So we first had the PCV7 introduced in 2000. You can see we started seeing, rapid declines in cases of invasive pneumococcal disease. And then the PCV13 was introduced for children in 2010, and you see we continue this decline in the number of cases in children. So this is a good thing. The problem is that for those of us who are adults now who, were not vaccinated against this, we are still, very susceptible to pneumococcal pneumonia. So here's looking at adults. So PCV7 again in 2000. So we saw a little bit of a drop. And then PCV introduced for children in 2010, recommended for adult immunocompromised adults 19 plus, and then there it is 65 plus. So you can see that we are declining, okay, but not as rapidly as we saw the decline in children. Now, another type of pneumonia is caused by Hemophilus influenza. And Hemophilus influenza was so named because they thought it was the causative agent of the flu before we realized that a virus was actually responsible for the flu. Droplets, aerosols, inflammation and accumulation of fluids in the alveoli. The alveoli are the little sacs in the lungs where gas exchange actually occurs. If they become inflamed, then it's harder for them to get rid of the carbon dioxide and pick up the oxygen. So this leads to shortness of breath, fever. It is resistant to a lot of different types of medications, but fortunately with Hemophilus influenza, we have a vaccine. The HIB vaccine stands for Hemophilus influenza type B, and we don't typically see this very often anymore. Now, the other very common type of pneumonia is what we refer to as walking pneumonia because it causes a very mild form. It attaches to the cilia. And remember I told you about that mucociliary escalator. So it interferes with the cilia being able to do their job, so it leads to mucus accumulation in the respiratory tract. Fever, cough, malaise, headache, tracheobronchitis, persistent unproductive cough. So this is the difference here. With pneumococcal pneumonia, we saw a productive cough. So they're actively coughing up mucus. With walking pneumonia or mycoplasma pneumonia, since the cilia are damaged, can't get rid of that mucus. So there's going to be massive coughs, but they're not productive. They're not actually getting anything up. Okay. Erythromycin or tetracycline typically can treat this. You see that it's the leading cause of pneumonia in school-age children and young adults. But again, it's a relatively mild form, so you don't see the hospitalizations like you do with the pneumococcal pneumonia. Here's an x-ray of someone that has the walking pneumonia, and both lungs are filled with this real patchy areas of inflammation. Now again, we can have other causes of pneumonia, chlamydial pneumonias, Klebsiella pneumonias, Pseudomonas pneumonia. So we have other forms of pneumonia, but those were kind of the three big ones. All right, so looking now at tuberculosis, which is another lung condition. I mean, technically, tuberculosis is a form of pneumonia because it is an infection in the lung. TB has been around for a very long time, and we were getting a handle on it for the most part And then we started seeing a resurgence in it, and now we have multiple strands that are drug resistant. So the Mycobacterium genus includes Mycobacterium tuberculosis and Mycobacterium leprae, which causes leprosy. And the mycobacteria are very slow growing, and they basically tend to hide. In this case, the bacterium produces these tubercles, and that's where the name comes from, tuberculosis. And in most people who are infected with tuberculosis, they may never know it, and it resolves on its own. What we commonly think of as TB is reactivated TB. This is the cough, persistent cough, the night sweats, the bloody sputum, the weight loss. Gave it its old name, consumption, because it basically consumed the entire body. The problem that we have with tuberculosis is because these bacteria are so slow growing, we have to treat with antibiotics for about a year. So a very long time. And that's why we're seeing these drug-resistant strains, because individuals were not taking the full course of antibiotics that they needed to. So the little red cells that you see in here are the Mycobacterium tuberculosis cells. So tuberculosis can be spread by droplets, but it can also be spread airborne because of that mycolic acid, that waxy lipid that's in their cell walls, prevents them from drying out. So they can persist in the environment for a long time. You see here, before pasteurization, milk was significant in the transmission of tuberculosis. And for the most part, a lot of times people, like I said, they contract it, it goes away, they never even know. The immune system takes care of the problem, they never even know they have it. Once we realized how tuberculosis was really spread, this was a sign from a railroad car, spitting is dangerous and illegal. They, learned that it was transmitted in droplets, and so you had these signs that were posted in public areas. They removed the spittoons. They didn't want people spitting in public anymore because the saliva would dry up and the bacteria could remain there. They were not, susceptible to drying like a lot of other bacteria are. A lot of people in the United States, may not have contracted tuberculosis here. They contracted it from some other location where there are higher rates of tuberculosis. So here are some lungs that are affected with TB. You can see these white areas here and these other little granular kind of granulomas where the tuberculous, in the tubercles where the bacillus would be found, where the bacterium would be found. So less than 10,000 cases in the United States, which is a good thing. About, 4 to 6% of TB occurs among people who are incarcerated. They're in close proximity with one another, so it can spread in prisons. You see their direct costs average from about $18,000 to treat drug-susceptible tuberculosis to $513,000 to treat the drug-resistant form. So this is tuberculosis cases in the United States from 1953 to 2018, and you can see we've gone from about 85,000 down to, less than 10,000. We do have antibiotic therapy, but we do have to be careful because we don't want to continue to develop resistant strains. So one method that's being used for treatment is called DOTS, or direct observational therapy. Basically what we're doing here is watching the individuals take their medicine. So and this can be done, in person, or this can be done through Zoom. And in the United States, we call it EDOT, which basically they log into a Zoom or other type of video conferencing like Skype or FaceTime. between the infected individual who's taking the antibiotic and the healthcare professional, and they basically just watch them take their medicine. So MDR-TB and XDR-TB, we have multiple drug-resistant and extremely drug-resistant TB, and these are becoming a problem. So our next infection here is pertussis, or whooping cough, caused by Bordetella pertussis, and the disease is caused by the different toxins that are produced by the bacterium, increased mucus production, constriction and hemorrhage of blood vessels, and the whooping cough, it gets its name from the sound that the child makes trying to take in air. So it leads to these violent coughs, and as the individual's coughing, they can't get any air, and so when they finish coughing, they kind of make this kind of sound like they're essentially gasping for breath. Fortunately, of course, we have a vaccine for this, but it's trying to make a comeback. We've been seeing an increase in the number of cases. The problem with this is, since it is the toxin that is, or these different toxins that are causing the illness, antibiotics really aren't that effective, and really only supportive therapy is what is available for treatment. So you can see, we were down. We were really low since we had the vaccine. We had a couple little spikes. Then we spiked in the early 2010s, kind of came back down, and we're kind of peaking up a little bit again. So here's when the first vaccine, around 1950, the DTP vaccine, and then in the mid-90s we got the DTaP and then the Tdap. These involve acellular pertussis. The old vaccine was a whole cell pertussis vaccine. So I'm going to see if I can show you these videos, if they will work. Maybe. So here is an infant girl that has whooping cough. You can hear the whoop. You can see her struggling to breathe. And now you hear the dinging of the alarm, so her oxygen is dropping as a result of this coughing fit. Infants, particularly those less than 2, 3, 4 months old, are those that are most at risk for dying from whooping cough. In older children, and adults, it can manifest as a cold. So, you know, you may not know that you're around someone that has it, because it manifests differently in different ages. So I have another clip that I want to show you. Well, maybe. If I can get to it, it's trying to link me right back to the same one, and I know I had a different one, so let me see if I can get it to come up here. Nope. Okay. Well, something has happened here. I've got the same link in there twice for somehow. I don't know how I did that. Okay, well, the other one I had, I actually followed up on the story with the family online. They suspected the child had pertussis, and they took him to the doctor, and they said no, because the thing about it is that a lot of doctors haven't ever seen pertussis, because we've had the vaccine for a long time, that, you know, a lot of new doctors had never seen it, so they weren't real sure how to diagnose it. So they sent the child back home, and the parents were making this video to show the doctor, like, hey, we really do think that this is pertussis. So another type of pneumonia is known as Legionnaires disease, and it was named because it was first discovered in 1976 at the American Legion Conference. So they were celebrating the bicentennial of the United States, and they were at this hotel, and they started developing this pneumonia, and some were dying from it. And it was there that we discovered basically this new bacterium that we knew nothing about, and it was named Legionella Pneumophila. More common in older individuals than younger individuals, but it is on the rise. In the United States, we are seeing more cases of this, and it's a lot of times you'll see it associated with outbreaks. Q fever, and the Q stands for query or questionable, because for a long time they had no idea what caused this. Now we know it's Coxiella burnetii, and this is almost it's almost exclusively seen in individuals who work on farms. They are exposed to the animals or to the ticks that are feeding on these animals, or the bodily fluids, the urine or amniotic fluid of the animal. High fever, headache, coughing, pneumonia, malaise, doxycycline or doxycycline with hydroxychloroquine will treat Q fever. So you can kind of see that we've stayed pretty steady over the past 15 years or so. Maybe a few more cases, but still not very many. We don't see very many cases of Q fever, and it's more common in the upper Midwest. And also in the summer, late spring, early summer, this is when ticks are most active. So this is when we tend to see more cases of Q fever. So I'm going to stop there before we get into the viral infections of the respiratory system.